last session, topic spice root session. Chairpersons will be Dr. Kailas.
So this is called a spice root session, and this is mainly for the young family physicians, the people who are doing their post-graduation, the people who have finished their post-graduation within 5 years of their practice. This is for that major chunk of people who are attending the conferences. So in this spice root session, we have we're going to portray a scenario where general physicians with special interest, how we can go through the training, what is the scope of it, and what kind of training that we can adopt. So we would like to call the moderator's chairperson for the session.
Hi everyone, I'm Dr. Susan. So for this section, I would like to invite Dr. Kailas P. He's a family physician with a special interest in diabetes, palliative care and geriatrics. Presently, he is working with Kerala Government Health Services in Thrissur as a medical officer in Community Health Center. Also, he is holding the additional charge of a district nodal officer in telemedicine in the same Thrissur. He is also FM 360-degree coordinator in the Spice Route India movement. Sir, Kailas, sir, please come, sir. Please be seated, sir. I would like to invite Dr. Ramakrishna Prasad. He's a board-certified family physician with expertise in infectious disease and public health. Currently, he practices as a senior consultant in the infectious disease and family medicine at Trustwell Hospital, Bangalore, and PCMH Restore Health. He is also associated with several networks focused on leadership and public health. He is currently president of AFPI-TN and AFPI chair in the primary health research and policy. Welcome, sir. I will welcome all the panelists, Dr. Shalini, Dr. Republica, and Dr. Sheela.
So how we have planned this session is that we are going to have young family physicians who aspire to become a general physician with special interest. And we are going to get them to interact with mature family physicians who are already practicing the respective field. So here we have Dr. Saranya, who is a young family physician who's graduated DNB Family Medicine 2 years back from Jahangir Hospital, and currently working in KMCH as a registrar in general medicine. So she's going to present about lifestyle medicine and introduce Dr. Shalini to us.
Lifestyle medicine, it's a medical specialty that uses therapeutic lifestyle interventions as a primary modality to treat chronic conditions like cardiovascular diseases, type 2 diabetes and obesity. There are 6 important pillars of lifestyle medicine. There are 6 important pillars of lifestyle medicine. They are whole plant-based diet, consistent regular sleep, daily physical activity, positive healthy relationships, stress management techniques, and avoidance of risky substances. Why lifestyle medicine is because non-communicable diseases, they contribute to 74% of all deaths globally, and 77% are in low and middle income countries. And tobacco use, physical inactivity, the harmful use of alcohol, and unhealthy diets all increase the risk of dying from non-communicable disease. So as you all know, these are all some of the lifestyle-related diseases like metabolic syndrome, periodontal disease, chronic fatigue syndrome, osteoporosis, gout, high blood pressure, high cholesterol, diabetes, obesity. So there are important differences between the conventional medicine and lifestyle medicine. In conventional medicine, the focus is mainly on drugs, and in lifestyle medicine, the focus is mainly on lifestyle change. In conventional medicine, the responsibility is on the clinician, and patient is usually passive. But in lifestyle medicine, the responsibility is also on the patient, and patient has to be very active. And the emphasis is on diagnosis and prescription in conventional medicine, and it is on motivation and compliance in lifestyle medicine. And there is less consideration of environment in conventional medicine and more consideration of environment in lifestyle medicine. So a healthy eating plate should contain whole grains, healthy protein, vegetables and fruits. And regarding physical activity, 150 minutes a week of moderate intensity aerobic activity and 2 days a week of muscle strengthening activity is needed to stay healthy. And regarding the positive social connection, we all know a positive social connection will boost our mental and the incidence of depression and anxiety will be reduced. And regarding stress, as we all know, stress is associated with many conditions like obesity, cardiovascular disease, and many psychological problems. And active steps to reduce stress will go a long way in reducing the incidence of those diseases. And also the harmful substances like cigarette, drugs, and alcohol, they have an impact on our health and they cause many diseases. And avoidance of those risky substances will go a long way in reducing the incidence of those diseases. And good quality sleep. 7 to 8 hours of sleep per day is very essential. They help in maintenance of healthy immune cells, effective functioning of the body's microbiome, balances insulin function and glucose intake, improves the cognitive function, memory and mental health, decreases cortisol level, decreases anxiety, depression, post-traumatic stress disorder, and decreases the risk of vascular dementia and strokes. So there are certain competencies which are required for prescribing lifestyle medicine, mainly leadership, knowledge of the lifestyle modification needed and the outcome to patients and their families, assessment skills, management skills, and use of office and community support. And so in different phases it can be practiced. The first one is pre-contemplation, then contemplation, preparation, action, maintenance, and relapse. So this is said by Hippocrates, the greatest medicine of all is teaching people how to not need it. And that is the motto of lifestyle medicine. So with this, I would like to introduce Dr. Shalini. She has completed DNB Family Medicine from Bangalore Baptist Hospital, and she's also a certified lifestyle medicine physician and diplomate of International Board of Lifestyle Medicine. She's HOD of DNB Family Medicine in Bangalore Baptist Hospital, and she's a teaching faculty for DNB students. Currently, she works as a senior consultant in the Family Medicine Department, running the Preventive and Wellness Unit at Bangalore Baptist Hospital. She's also the Director of IT, Communications and Networking, Social Media at Indian Society of Lifestyle Medicine, and has over 12 years of experience working not only in the rural community but also in the urban underprivileged areas.
Now I invite Dr. Hari to talk about infectious disease and introduce Dr. Sheela.
Good evening, everyone. For the past 2 to 3 weeks, we were having many discussion in our Spice Route group to organize this session, especially sponsored by the Spice Route organization. And the main concept is to make the general physician to take up special interest in various other fields. So we came up with these 4 titles like infectious disease, lifestyle medicine, palliative care, and general care. Our ma'am has already elaborated on lifestyle medicine. Now in infectious disease, for we all know for past 2 years we are running behind to tackle this global outbreak, and many more newer infections are coming up. As family physicians, I like to ask ma'am her insight on how to manage these infectious disease as a role of family physicians. So I like to invite Dr. Sheela ma'am, who did her UG at Rajamutaya Medical College, DNB Family Medicine at Sundaram Medical Foundation, and fellowship in general infectious disease in CMC Vellore, and currently consultant physician at Apollo Hospital, Chennai, to give us her ideas on infectious disease for family physicians.
I invite Dr. Anitha to talk about palliative care.
Good evening, one and all. I am here to brief you about the basics of geriatrics and palliative care, more of which will be discussed in detail by Dr. Republica ma'am. So why are we discussing geriatrics today? Why is geriatrics important for family physicians these days? Can some of the PGs tell me? No answer from the PG students because...
Can I answer, ma'am? Or PGs, can PGs answer, by the way? Why do we need to know geriatrics in general practice?
Very good. Excellent, ma'am. So, as we all know, there is the demographic shift that is happening in India. So, I'll be enlightening more on that. So, geriatrics is the discipline that deals with medical, mental, functional, and social aspect of older persons. So, as Madam told, the percentage of elderly is steadily increasing in India. According to 2011 census, they comprised 8.6% of the population, and it is expected to grow to 21% by 2050. So with this growing population, most of our general practitioners or family physicians are not well trained enough to deal with them effectively. So why do we need to learn specifically about older people? Because disease presents in different ways and in atypical ways, and it can cause more morbidity and mortality in older patients rather than in younger people. Progress of disease is very rapid, and apart from health, there are other sequelae that are more important in geriatric patients. Like in most of my patients whom I see, it is the social consequences, that is the absence of caregivers and the financial constraints that are more important, more restraining than the disease itself. Again, these patients do not present with a single illness. They already have a background of so many illnesses. So again, the physiological reserve is also very less. So the outcomes might not be as we expect them to be. So since the presentation of disease is different in geriatric patients, the skills required by the family physician also are slightly different. They demand more skills because of physiological decline, the increased frequency of more illnesses. More importantly, the disability that these patients have, the multiple disabilities that they have, might prevent us from obtaining a proper history, like they might be hard of hearing, they might not be able to understand, they might have dementia. So it is a limitation for us to obtain a proper history, and also obtaining consent from them might be a big restraint in many cases. So again, treating of disease is also different, entirely different. So in all three aspects, the history taking, examination, diagnosis, and treatment, all four components of the treatment, they pose challenges in geriatrics. So these geriatric patients may benefit more from more invasive therapies than the rest of the population, and some of the treatments might not work well for them. They might have more side effects to therapies because they might already be more taking so many medications. So as I had earlier mentioned, so with the steady increase in the geriatric population, we will be seeing more of older people in our daily practice. So according to recent statistics, it is shown that 90% of older people see their FP at least once a year. Around 20% of our consultations currently are for older people, and in these patients, consultations are more complex because of the reasons I had mentioned earlier. Since we are FPs and we have to have a continuum of care, we might be knowing them for several years. So treating them might be much easier than any other specialist whom they see for specific problems. So GPs might act as community physicians dealing with geriatricians who might be able to liaise with other specialists to enable effective healthcare delivery for the elderly population. So We see a bright career in geriatrics for family physicians in India. Many of our geriatric departments in medical colleges are headed by family physicians themselves. We also see a rise of geriatric departments in corporate hospitals. We see geriatric centered clinics, and also your clinic could be labeled geriatric friendly if you developed special interest and enhanced your skills regarding the same. Next, I would be introducing palliative care. The word palliate itself is to make somebody feel better when they have an illness that cannot be managed or cannot be resolved completely. So WHO defines palliative care as an approach that improves the quality of life of patients and their families facing the problem of life-threatening illnesses through prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So WHO says that these are the key elements, like we need to provide relief from pain and symptoms. We need to affirm that life and death are normal processes, and we need to get the patient accustomed to it gradually. In palliative care, it is neither intended to prepone or postpone death. So we need to integrate psychological and spiritual aspects along with treatment. So we need to also offer a support system for the patients to live actively until death, and also offer a support system to help the family cope. So that would be the most important challenge. Helping the family is the biggest challenge. As I have seen in my practice, we see that recently I had a patient with terminal lung cancer. She had stage 4 adenocarcinoma. She is on palliative care right now, but it is a family that is suffering more. Her husband has developed major depressive disorder. Her son suffers from psychosomatic symptoms and generalized anxiety disorder. And the child in their family receives no attention because all the attention of the family is diverted towards the patient. So it is a family that requires support. This can be provided only by the family physician. So, yeah, of course, a team is required for palliative care. So palliative care is not only at the end of the disease, but it could start right from the diagnosis of the disease. Like right from when the diagnosis starts, chemo radiation starts, from then the components of palliative care could be applied. So treatment would involve correcting what could be corrected. Even though it is a life-threatening diagnosis, things that can be corrected, for example, candida that causes dysphagia, that could be corrected. And then counseling to help the patients accept their diagnosis. And next is drugs to control the symptoms. Drugs come only in the last phase of treatment. So the main components, as stated in the definition of WHO, is physical care and medical treatment, psychological care, social and spiritual care. So physical care would include pain relief, symptomatic management of other problems. For example, they would have weakness, fatigue, drowsiness, etc. And then diet, designing a diet that a patient could eat. Psychological care, since the family physician knows the patient for a long time, they would understand how the patient feels, and counseling would be tailored accordingly. So, So since a lot of counseling is involved in palliative care, family physicians should equip themselves with the art of counseling. They should learn counseling skills. So, as we all know, with the increased burden of non-communicable diseases, we have an increased burden of cancer. So cancer and other terminal diseases are on the rise. So since family physicians are close to families, we might be able to address the problems of the entire family as such. So as mentioned earlier, an important component of family practice is home visits, which other specialists might not be able to do. So we as family physicians could go to their home, look at the situation at their home, and address their concerns in a more effective manner. So, and nowadays the trend is that people live longer, and most patients' families do not want to admit their patients at the end of life. 74% patients who are terminally ill and their families, they want their they want the patient to stay at home at the time of death. So that makes family physicians more relevant for palliative care now. So, and it is stated that 90% of terminally ill patients are currently taken care of by their family physicians only currently. So, so it is more important that we upgrade and increase our skills. Thank you. Now, I'll be introducing Dr. Republica. Dr. Republica Sridhar, a family and palliative care physician, a medical graduate from Sri Ramachandra University in 1992. She has been practicing over 27 years as medical director, founder of RMD Nursing Home, a hospital with 25 beds at T Nagar, Chennai. Founder, managing trustee of RMD Pain and Palliative Care Trust, a non-profitable organization that focuses on palliative and hospice services for lower socioeconomic background. The services offered are inpatient, outpatient, home care, awareness, community-based palliative care in the state, which is a pilot project. She is also the co-founder of Aura Holistic Wellness Center. She is involved in cancer awareness, palliative and hospice care awareness, anti-tobacco movement, HIV awareness, Pink movement, and several other important movements. She is an on-call consultant at several renowned hospitals, and she is a member of several organizations and medical associations. She is also the recipient of several prestigious awards. So over to the speakers.
Since during my undergraduation, I would say, I was interested in bugs, the bacteria, the virus. It all enthralled me. And after finishing UG, I was just looking for the way to enter the infectious disease side. But I saw that during the national board, I'm talking about a decade ago, the journey started. I wanted to do the PG, and I saw this national board. If you do DNB family medicine, you are eligible to do fellowship in ID. I don't know, none of you have seen the brochure, but it was almost 13, 15 years ago. I saw that we have an avenue. If you do DNB family medicine, national board has mentioned, you are eligible to do fellowship in infectious disease. I saw the brochure, I got too excited. Wow, what a way to enter the infectious disease. So without blinking a second, and it was a God's grace, there was not even an entrance exam to enter DNB family medicine then. So it was just a wisp of questions by the director of the hospital at Sundara Medical Foundation, where I already was practicing for past 10 years. I was having rigorous family medicine clinic for 1 decade, and I wanted to upgrade myself. I said I wanted to do DNB family medicine. So the medical director said, yes, you are given the seat. You can enter the DNB family medicine. 2 years into the practice, I saw that I wanted to do ID, and the national board has scrapped our eligibility. The family medicine is no more eligible to do ID. But my dream went on and on. I wanted to pursue that. So like Dr. Lizzie was mentioning yesterday, you need to take your curriculum very seriously. So our curriculum, the Sundara Medical Foundation curriculum, was very strict, where they said you can go for 6 months of elective postings, right? So I took it very seriously. I used to go for all the subspecialty postings. 10 days I was sitting in the ID clinic in Sundara Medical Foundation, and I saw how the ID, Dr. Ram Gopal Krishna, was tackling each and every fever cases. I heard very exotic terms like melioidosis and non-TB. I was like, what is this melioidosis? I have heard only typhoid all this decade in my clinic. I have never heard of melioidosis. Then that triggered me, and 1 month of posting in DNB family medicine, you can go out of your institute and go to another place and do. So Dr. Ram Gopal Krishna, who is an ID consultant in Apollo, he saw the interest in me. He said, the 1 month you can come and do it in Apollo. So I took help from our institute and went to Apollo, and I had a full observership 1 month, morning till night, just like in any ID fellowship. I was doing night duties also and seeing how they are looking up the OP, IP, where I had introduction of seeing the HIV patients in the clinic, how to deal about it. And he saw that my way of approach, apart from the internal medicine guys, is entirely different. Being a family physician, the way I approached the patient was entirely different from the the internal medicine people were approaching. Hats off to the training from Sundaram Medical Foundation, and hats off to the family medicine training, where it was like not the specific disease oriented. The way I approached the case was like a family physician. So it gave me immense ticket to pushing furthermore, and they said, okay, after finishing family medicine, you can come and join here. So that is how I joined Apollo for a couple of 2 years, rigorous training, I would say, into ID. And then thanks to CMC Vellore, who also recognized family physicians to do infectious disease. And they saw the approach I gave them. Why you want to have, as a family physician, we have to give them the reason why are you applying for the family medicine, infectious disease in CMC Vellore. You have to write up an essay. I had to say that I am a family physician, I have this practice, and what I see is diabetes plus infections. They go hand in hand. Like all this while we see anesthetist, physician pediatric couple. It is like diabetologist. Yes, my hubby is a diabetologist, and I was like infections. It goes hand in hand. So I see like 50, 60, 70% of our patients are diabetic patients, and he started sending me all the fever cases. Okay, cellulitis, diabetic foot infections, pneumonias, UTIs. You see, I don't know what is that antibiotic you are writing. So thanks to training from CMC Vellore, where it gave like in-depth, in-root training again. And here I am in front of you talking about my journey.
Hi, good evening to all. First of all, I thank the organizing committee for this invite, and a brief presentation on the lifestyle medicine and my intro. Thank you so much, Dr. Saranya. So like a very budding family physicians here, sitting here. So I started my career way too behind in 2010. So I come from the batch where there was no centralized counseling. So when I said I want to take family medicine, eyebrows went up. People were like, are you mad? What is this? Why you want to take this branch? Because people are not even heard about it. So I'm of a person who like curiosity in the branch. I see that a lot of other specialties having a very tubal vision when it comes to disease management and approach. So I felt the family physician, you have that curiosity going in you. So when I started my career, it was more than evident that there was a dire use for addressing the root cause of the problem, the issues. So otherwise I felt it to fester till they became too big. That was the reason I was just wondering, after finishing my family physician, I was just wondering, what next? So there it didn't end my curiosity. I was just wondering, can I do something in palliative, which I was really fascinated with my team in Baptist Hospital. We run a very good palliative center where I had taken my exam and I certified there. Then following that, I was just thinking, no, there's something else we can upgrade ourselves. So this kind of upgrading yourself happens with family physicians. And when a person approaches, when a patient comes to you, you have more than enough to give them. You have more than enough to kind of connect with them. So that led me to do even geriatric certification. So following geriatric certification from CMC Vellore, lifestyle medicine. This happened when I started understanding this. There is so much of growing evidence in lifestyle changes. And you can make a remarkable change in an individual. So I was introduced to lifestyle medicine, and it immediately captured my attention, as it was the one true calling for me. So lifestyle medicine, just want to tell about few numbers here. I see a trend where from 1999 to 2016, so wherein if you talk about diabetes, it's from 25 million to 65 million, and I'm sure the numbers are more now. And if you talk about any other complications, including cancers, it's about 28% till about 2016, and it's way beyond that. I look at the model, so every clinician, physician sitting here, you develop your own model when you're practicing, actually based on different strata. What can you offer to different strata of patients coming to your clinic? So that way, I was just wondering, when it comes to healthcare, it goes with three corners of a triangle, I would say. The first corner would be your healthcare. What sort of healthcare you can provide? And the second one, I would say, what is the experience of the person when you come, of the patient who comes to your clinic? What is the experience that patient feels? And the most important is the cost. So it says that NCD, 70 to 80% of the GDP goes for the NCD care, and it is the latest data says that it pushes an individual to poverty by about 7% of people. So I see these numbers to be a very, very big phenomenon. Lifestyle medicine is not about replacing any treatment. It goes hand in hand with any physicians. So it's just walk the talk. So there were the pillars which Dr. Saranya was mentioning. I take few words from conclusion of Dr. Isaac and ma'am who was presenting. It's the same behavior change model, which is a very challenging task. And we, being family physician who provide holistic care, I think we can go way beyond to treat them. And the second thing I would say as a geriatrician as well, so when we see sarcopenia, which is happens in 50 years of age, when I see that, I say, when we see frailty at 60 years of age, what can we do then? You can still do something. If a palliative care patient comes to me, I can still do something. And that's how lifestyle medicine actually stitches with every patient care. It's not replacing the treatment. And that's how I got connected with Indian Society of Lifestyle Medicine. There are a lot of work in progress happening. We just finished our third international conference where we had about 700 delegates attending all over the globe. And we had WHO consultants speaking there. We had national and international faculties talking. And we understood that lifestyle has become a movement, and we need more evidence from Indian scenarios to act much faster than what we look like the NCDs are happening these days. Yeah, I'm happy to take any more questions.
Thank you so much, first of all, to accommodate such vibrant sessions. Everything is so diversified, and I know it's very interesting. 1994, I started as a family practice. Okay, and my mom just looked at me. She said, "I don't think you can work anywhere under nee timir pudichodi yaar kiliyo nee vela seiya maata." That was the first thing she told me, and she started me with the clinic. She said, "Edho onnu pannittu po." You know, I come from a very traditional Gujarati family where my dad didn't want me to do medicine, but I got into medicine so that I will not get married for the next 5 years. That's a true story, huh? But I didn't know my destiny was so serious that it brought me to palliative and geriatric care. So even now my professors look, Republica, I can't believe you've taken up such serious mode in life. Now the reason I'm telling is all of us will have a soul search, and family practice is one thing which will give you satisfaction at every day. It's not you're seeing the same and same monotony. Because we are seeing, you know, I work with doctors as a palliative care physician, oncology, to see day in and day out thing. You see one side, it'll be a child, the next there'll be an elder patient. It'll be like, you know, multiple people, and you're going to satisfy everybody then. Now it is very, very interesting because I'm into geriatric and palliative medicine for over 28 years now, okay. And my daughter looking at that, she said, "Amma, yaar ketalum you're going and telling, you know, she's finished her business management and she's opened a holistic wellness center in which we are running it for past 2 years. Her answer was only one thing. For everything you all tell immunity, for everything you all tell lifestyle, then why can't you change that rather than giving them medicines?" And you know, looking at the people who are depressed and all that with lot of pain, integrated wellness. So it's a wonderful, you know, diversified, I think, kudos to Vivek to put all this together and the organizers, because this is the in thing. I mean, the topic today, I'm sad most of them have you know, missed the session, but youngsters are there. The future is geriatrics, the future is palliative medicine, the future is thing, because you people can fit in everywhere. I will just, you know, sign off. I don't want wait, just lack of time, and we are having experts here who can also tell. Lifestyle, life expectancy is definitely going up. Geriatrics have gone up. We are also handling almost 8, you know, senior residency home, other than palliative medicine and all. I do the medical care centers for them. RMD is doing. The need has become diversified. COVID has proved family practice people only can reach to patients. All the specialists took a side away. So we have a reality which came, and I think you people should pitch in, open up avenues. A day before I had an elderly who walked in the house, suddenly he became mad, very restless, beating people, you know, mild temperature 101. So the children decided, he was a 78-year-old man, male. They said we took him to a psychiatrist. but on the marundu pota kuda he's very violent. They had given him quitipin and all that. Can you believe what was the problem? Anybody? Pain. Yeah, pain. He was restless. He was not sleeping. Anything else which you all can think of? Delirium. It was very true. Febrile delirium could be, but he was delirious definitely. Nothing. He had a prostate. Urine had blocked. The minute I gave catheter, that man is sitting and eating nicely, dosa, gisa and everything. The reason I'm saying is, a family practitioner can see this immediately. If you go to a specialist, either it will be a neurologist or something because they are lost. Patient is overdosed. The other thing I definitely want to tell is polypharmacy. Please, in elders and every time you people keep seeing comorbidities, recheck. I've seen patients with 4 types of, antiplatelet drugs. Nephrologist gives one thing, this one gives one thing, and then they'll tell renal failure when the cloplet is so high. Unless you withdraw that, this is not going to come down. So this is one thing as family practitioners we have to see. The other aspect of palliative medicine, as very well said, it is not at the end but right from the beginning. So if the pain management, early intervention of symptoms can be made and taken care of, definitely it would go to a long way. And as family practitioners, we have, I won't say the others don't have empathy. They don't have time. We have the time and the empathy, and we know the background of the family because they are able to open up to us. Okay, I can't go write a very expensive medication for a person who's from a very, very lower middle class family. And they come back halfway through. Many a times we physicians don't even ask why you've stopped the medicine. Rather we shout at them, why you're not taking the medicine? That particular person might not have money. I know elders where the son is not sent money for 2-3 months, not able to buy the medicines, nobody to go buy them the medicines. But we shout at them, who asked you to do this? You ate lot of sweets. You took all these medicines. You did not eat. You didn't take the dose which I gave. Because you're scared, you'll be blamed. But unless we go to that platform, and that family physicians can definitely make. So from 94, slowly that soul search, as every one of us have here in this hall, I truly believe that. Because there is lots more to do and there is lot of learning, and it is a diversified platform which you can reach out. So when my first patient was an elderly lady who donated her entire property to a temple just next to my hospital. She was thrown, nobody was there to look after, she had a uterus bleeding. That's a temple which sees Madi Acharam and all that. She was straight bought in, she was my first patient. She was elderly with uterus cancer. I didn't know I was doing palliative care or geriatric care, no. All I did is family practice, I'm trying to help a patient. That is when I got introduced to geriatric palliative care over a period of time. So every time, every patient is an opportunity, and as there are so many diversified fields, you can see where you all can fit in. It is not that you have to be under an umbrella. You yourself can become an umbrella. When I started my hospital, it was just a clinic with 5 beds. Today I have 140 beds all over. You can do it. Everybody can do, unless you have that drive and the dedication. So I think palliative care has a lot of need now, evolving with assisted living to terminal ill or end of life care, and integrating with lifestyle, which what we are doing. As she rightly said, you can do a lot of improvement. Imagine having an infection control, a lifestyle, and here, one of y'all can have a family practice with all we consultants walking in. You're going to give a quality of life, and that's what we are talking about. Thank you so much.
Wonderful, 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 ma'am. So, yeah, we're continuing with the panel discussion. It's wonderful that you have given the perspective as to, it looks like all of the 3 specialists, the special interest general physician seems to have a very bright future for the respective field. So I would start with Dr. Sheela. What do you think is the future scope of the field of infectious disease? And how do you see this community infectious disease playing in the future after the COVID pandemic?
Mark my words, it's going to be magnanimous growth. So a decade ago, I was telling my hubby, when I just did my diploma in allergy and asthma from CMC Vellore, I said, the future is going to be diabetes. So go and please do course in diabetes from CMC. And it became a big boom. Now he calls himself as a diabetologist, not even a family physician. So the same moment I saw that the next big thing is going to be only communicable diseases. So the non-communicable diseases, I have this kind of entrepreneur mind, because I see that the pipeline towards building up new drugs is only non-communicable diseases drugs were going up to treat diabetes, hypertension, all these things. But what I saw is there is a dry pipeline where they are not at all making any kind of, not even a research is happening in the field of antibiotics. Then I started thinking the future is going to be infections. The future is going to be bioweapons. The future is going to be infections, infectious disease. So I started thinking about it a decade ago when I did my PG, DNB Family Medicine. So I said the infections, because I started seeing lots of this typhoid. I see that none of them is responding to my ciprofloxacin. I started writing left and right, east and west, whatever you say. The ciprofloxacin, it said like within few years, it became resistant to it. Well, we are talking now, 95 to 98% of us are already intrinsically resistant to ciprofloxacin. So don't even write ciprofloxacin. So my practice taught me that I am in the verge of antibiotic resistance while I was in my clinic. Then I thought myself, after finishing DNB Family Medicine, I need to get updated on how to tackle this resistant bugs. While I was in the clinic, I was not even in the ICU. What you are seeing, what you heard yesterday from Dr. Ayyappan is tip of the iceberg. Today, I go around 50-60 hospitals in the Chennai city where the patients are dying like flies because of antibiotic resistance. Not even the COVID. I am talking about the pre-COVID era. I was running madly around the city, seeing patients dying of UTI, MDR bugs, XTR bugs, whatever be it, colistin, tigecycline. I started writing chloramphenicol. I don't know whether you guys have ever, you might have heard about it in the pharmacology. I have been pushed to use the chloramphenicol in the practice. We don't have any other antibiotics. So what is the root cause? Again, I thought it is the family physicians. It is the general practitioners. We have to take the torch in our hand now. Just like how we took the torch for the diabetes. How we started cleaning up the whole community, saying that you need to take the medication, you need to take care of the lifestyle diseases, whatever the colleagues were talking here. The same torch bearers have to take up this MDR initiative. The multi-drug resistant, it's the tip of the iceberg. I have seen more deaths than the COVID because of the MDRs happening in the ICUs now. Not even the community acquired, the hospital acquired, everything. So we are going to be the torch bearers. Like yesterday I was talking about, we should know our antibiogram. We should know our typhoid bacilli. We should know our TB bacilli. So there is a big scope, like a huge scope for infections in the practice, because most of the practices, fevers we see. And thanks to India, we have year-round infections creeping. We have all the tropical infections. And we have diabetes. Diabetic people are sweet people. Infection loves them. So infection and diabetes go hand in hand. And it is a win-win situation where you've got to be a diabetologist, you start treating the diabetes, at the same time you will be treating the infections like the UTI and the diabetic foot infection. So take up the initiative in this, be a part of the huge group which is going to be, starting from today onwards, we will be sending you, when you are become the member, already you will be getting updates from us, what is it going to be. So, as I was mentioning yesterday, we can start up the antibiogram in each and every locality wherever you are practicing. See what bug you are treating. It is not the fever we are treating. You are going to be the fever specialist, not even ID specialist. We did it fever, right? In our clinic. Don't even call us ID, infectious disease. It is there in front of us. We just have to see the clarity in it. Which fever I am treating? Is it a undifferentiated fever? like malaria, dengue, chikungunya, blah, blah? Or is it any specific organ-oriented infections you are seeing, the urine infection, urine abscess, liver abscess? Because I have seen people dying of pyelonephritis. We keep treating them with ciprofloxacin. Please forget about the quinolones. Don't even write quinolones like Switzerland for the next 1 decade. 10 years, don't write quinolones. Because, mark my words, it doesn't work. It doesn't work in UTIs. So, it is a tip of the iceberg you are seeing now. There is a huge ripple of waves going to come in the next few years, where we see each and every patient coming up with infection, not getting treated up with which antibiotic we need to treat. It is you, the family physicians, going to tell even the government, this is what is happening in my community, this is what my antibiogram is, this is what we have to treat. Buzz the red button there. This is what is happening. I am seeing a spike of measles happening. I am seeing the spike of conjunctivitis happening from our community. We are going to be the buzzers. So it gives, like, unlike to that of the other specialties, I would say, it is like a MCQ. You get the bug, you hit them hard with a good antibiotic, and buzz, the patient is good, smiling in front of you, no fever, and the UTI is gone. It gives you immense pleasure in treating these kind of cases, right? And diabetes, yes, if you keep that also under control, it goes hand in hand. So it is going to be a win-win situation for us, the family physicians in this specialty. And please join the moment in this antibiogram and stuff. We will be sending you the note. Thank you.
Yeah. Dr. Republica, can you please tell us, what do you think is the future scope of this palliative care, geriatric care?
As I told, the scope is really high, and COVID has proved, as I said, there is an increase of home health care. Okay, telemedicine, you can definitely become. All the insurances are accepting home care now, if you notice. So definitely there is a scope. You people can also get empaneled. STAR is coming up with the empaneling doctors as their consultation, as an OP itself, outpatient itself. So you know you can enroll your clinics, because I've done it recently, that's why I'm telling you all. So enroll, you have an open thing. So home visits is one aspect. Clinically, then you will have a diversity right now. If you have an integrated palliative or thing, you're going to see a holistic way of, patients. Geriatric is another end, not only having them coming to the clinic, but you can reach there, you can go to communities. Like, you can reach out to a hospice or reach out to a old age home and do what, because we are doing the facilities. There are around 75 residential properties in Tamil Nadu, out of which only 3 are having medical center. I just recently did a survey and we've launched something called RMD care, which is going to give, multiple care. So we did a survey now. Can you imagine there are 75 well-known. They are doing it like real estate. They're making the elders buy. But there is no medical thing given there. You can definitely tap such areas where there is a need of doctors. You all can create a team. You can do home care. You can create a team in your particular community. Those things are, when I mean home care, it's not about providing nurses, but for any emergencies or whatever, you can be readily available. And you should start becoming loud. That is what it is. So as you rightly said, palliative care is another aspect. Cancer, colostomy care. People don't know. The oncologist or the things, they don't train the people. They're just sent off. Yesterday, post-operative, we had 3 colostomy patients just getting admitted in my nursing home because they don't know how to handle it. But if the same thing, if they can come back to their community and you tell, okay, I will take care. So you can look after colostomy care, because it will become like a procedure, ascitic tap, simple procedures. People can connect up. I've told Dr. Vivek also, you all can come in groups or whatever, we can start training. Simple wounds, how to do it. As she said, diabetic wound, gangrene. People don't know. They just do some vague dressing to some vague clinic. But if you're a specialized person, there is another scope which you can do. Elders, as I told, dementia, people don't know what is happening. They suddenly they think there is giddiness, they immediately go to a neurologist. Finally, it could just be a simple vertigo, or they would have taken 2 BP tablets. I've seen patients like that. Elderly taking 2 BP tablets, BP settles down. giddiness, the son from the US is telling, go to a neurologist, go to a neurologist. Her BP is only 90/60. On the way itself, she fell off. No, this really happened. I'm not at all, she fell down. Then they called me. Then I said, no, what, nothing wrong with your head. You've taken, then she said, rendu ore color irundhathu edho eduthukiten. You know, simple things. If you start handling the palliative care or the elderly people, definitely there is a lot of scope. It is not only as a medical practice, but even as a career. You know, you people have, only thing is, geriatrics need a lot of patience. That is one thing which you have to see. And culturally, everything is diversified. Chennai is different, you know, Madurai is different. I had a hospice till COVID, 11 years. Inga community is completely different. You talk about prevention, they look at you like, you know, because they are not prepared for that. So you have to see what is your community, your socio-economic background, see the family dynamics where you're handling, and accordingly, you know, you tailor make your program for your community. That is very, very, very important. If you tell anybody that it's terminal, then home cares, you can create. It's not that you have to go everywhere. You can also, you can just recruit a physician assistant who do an equal job where you can monitor. Definitely home health care and OP has become a part and parcel of insurance. You just have to empanel your centers or your clinics into, you know, OPD and things like that. Star has come up, Bajaj has come up. Just for OPD, they are giving insurance. So your clientele base will increase. Elders, you can also tell them we have insurance and things like that. So that the scope is really, really high, Vivek. It is really high. It's just that people don't know whom to reach. You know, there are people who are cheating, caregivers cheating. I had a dementia patient. The children are abroad. The wife died of cancer 6 months ago. He has the whole access of the debit card and all. He has transferred 8 lakhs from that old man's account into his account gradually, telling I'm buying this, I'm buying that, and that old man is becoming dementing. So, you know, that's another thing. But if you become a pivot point or a caregiver support for that, I would call it caregiver support, not just a physician, but an entire support, socially and, you know, physically or whatever. Definitely there is a lot of scope. I think this is a huge topic, Vivek, you know,
Yes,
palliative care separately and geriatrics, I think he'll agree. And always Kerala has been a forerunner for, you know, geriatrics or palliative, you know, looking at the community based and stuff like that. So that is what, it's a huge topic, but maybe we can even have another session or a Zoom. Please feel free, we can talk about it. Maybe you'll give us common FAQs. With that we can, you know, that will be a better way to address the gathering.
So, yeah, you pointed out a very important thing about health, being a health advocate to the people, elderly and palliative care people. Now, Dr. Shalini, what do you think is the scope of lifestyle medicine coming in future? We all see that the non-communicable disease is on a high rise, but lifestyle medicine and its role, especially after the conference like what you have conducted, how do you see the shift of scope, and what are the stakeholders in this particular thing?
So lifestyle medicine, I would like to start. I'm sure Dr. Sheela will not deny if I say the infectious disease, the base is poor lifestyle. That's there. So family physicians, we see all the array of disease, like from infection to non-infectious disease. I feel lifestyle medicine, especially from the conference and interacting with the global speakers and thing, I understand that it is phenomenal. We see physicians showing interest towards LM. The problem with this LM is it's been diluted very, very much. So it requires a regulatory, especially with evidence-based research and, you know, clinical guidelines. How we follow algorithms for all our diseases. Lifestyle medicine requires that, so that we don't kind of have an adulteration with the coaches or the trainers out there. So as a family physician and a lifestyle physician, we need a sustainable model, because NCDs, as I see, it's a slowly progressive disease. So it also has a very long latency period. I see a lot of intervention can be done during this long latency period. And also the longevity, if you see at the independence, 1947 is 30 years, was 30 years, and now the longevity is 70 years. And 70 years is equal to morbidity, is what everybody thinks. And can we change the quality of life? That is what we look at LM. And as a LM physician, I would proudly say that this is evidence-based what we practice. It is not something read over social media. I'm sure our patients go through a lot of social media, do a lot of fasting. But this we have to walk hand in hand with the patient and not leave them. So I would also end my discussion because of the time constraint. If you empower a man, you're empowering an individual. If you're empowering a woman, you're empowering a family. So as a family care physician, you're actually addressing the entire family. So I have 2 prescriptions in my clinic. One as a family physician, and second, very, very minimally prescribed medicines. Second, I have a separate 20-minute session to talk about all the pillars. I was just asking, are you sleeping well? That itself will answer my question for how the patient is doing. Thank you.
I have one last question to Dr. Republica. Now, many of these young graduates would love to, take some kind of immersive training to understand what is, any of these general physicians with special interests are actually doing in their day-to-day activities. Now, Dr. Republica, do you think any of this immersive training or shadowing program is possible for these young family physicians, and how do they can go about it, and do you have any kind of courses or certificates for the same?
Yeah, actually yes, IAPC is running a certificate program, as all of us are aware, that is Indian Association of Palliative Care. RMD as such, we have a 3-month certification program in which one we've tied up with Savita Medical College. So we've recently done it up, which has got an integrated module with geriatric and all that. One more good news is palliative medicine has also come with DependB and MD program. Okay, Tata has got, Manipal has got an MD program if you guys are serious. DependB has also come. Right now, Adyar Cancer Institute has done. I have applied, they've asked me to reapply next year. But Adyar Cancer Institute have got a DependB in palliative medicine. So people who want to, take it up that way. There are other, 3-day workshops and things like that which regularly goes, because I'm a secretary of Tamil Nadu Palliative Care Society. So we do a 3-week, sensitization and intensive programs with Tamil Nadu Medical Council credit points, and we give them certificates where this will become a, program with this badge you can start definitely, start practicing itself. Because it's not a very complicated, because I was amazed by your communication skills. I think we do only 1/4 of sessions even in palliative care, though palliative care needs a lot of things. So you people have already crossed the bridge. It's only the little bit of pain management and those things definitely plays a lot of roles. I totally agree with her about infection, because urosepsis and nosocomial infections are 70% of the death which we see in palliative medicine. The patient does not die because of the cancer also. So those are the things which as family practitioners you should see. I had a lady, I can never forget, 2 patients I'll never forget this. One man, he had a lung cancer. He was getting treated in radiation, oncology and all that. He had severe pain. So they just referred from a very well-known, renowned oncology place. They said it is completely palliative care, the lung is completely spread. And he has severe pain and all that. To my shock, he had varicella infection, which was not noticed. And the pain was because of that. It was a neuropathic pain. The minute I treated that, he became absolutely okay. Whereas he was given all the fear, you become terminal, your cancer is spread. So if I did not have that family medicine blood or background in me, I would not have examined him fully. I hope you understand what I'm trying to tell. There was another lady who came, she had breast cancer with secondaries in the lung. Severe pain. She came and told, Doctor, just na tarkula pannikira, ennala vali thangave mudila, and she was screaming. I was like, okay, we gave first day, as usual, I started with morphine, I gave patch, but she said, no, my pain is there. Then I said, why is there? So we should look into something. Let's do an X-ray. Then all the oncologists, no, it's completely spread. What are you going to do? We did a, thing and all that. Then I said, no, let's do an X-ray and a ECG for whatever is the benefit. And she had a MI. The pain was because of MI. And 3 days we are treating her with morphine. I hope you understand what I'm saying. If I had not had that family practice background, I would not have thought beyond that. I would have been in that focus of oncology care or pain management care. What next, what next, what next, only a family practice can do. Why this is, why this is, why this is, what more, am I missing something? Because we always have a widespread, background in us. Right from head to toe, we keep thinking why this is, what is the root cause, what is the root cause. That really helps in practice. So definitely IAPC course is there. We were launching, I think January we are launching the Savita program. Other than that, to start off short, we can do 2 or 3 day sensitize program with the Tamil Nadu Medical Council thing and Tamil Nadu Palliative Care Society. With that, we can start off courses. So that is for immediate start. Definitely we can do that. And it is, again, people think palliative care now, we have to have morphine license. Abdila onnume kadiyadu. Nothing at all. Because now all the drug companies are also, now there is a new drug which has come, which is a morphine, a synthetic morphine, which they've launched last month. So it is not that difficult also. So Munadi it was a myth. You have to have, if you are a palliative care, you have to have a, morphine license. Now it is not that way. So anybody can, once you all are trained in the right way, yes, you can look after.
Wonderful. I like this idea of exchange programs. So we have in Spice Route a 360-degree exchange program through which young family physicians like you and me, we can identify places of training like this, and we can get it certified like how she said, as well as from the AFPI Spice Route group to get it certified as a exchange program. You can reach out to us for the same. Dr. Shalini, do you think, is there any immersive program that we can undergo for the lifestyle medicine for the same?
So for now, we have the Indian Society of Lifestyle Medicine Board certification. It happens once a year. And it's basically through, we have American College of Lifestyle Medicine, British Society of Lifestyle Medicine, and few more like Minnesota and things. But currently, this is the only exam which is there. But I strongly believe there should be an immersive program where you will require at least 2 to 3 years. And as every other branch in medicine, it's a teamwork. It's a team collaborated work. So you need a team to work like that. So another 3 years of, so close to 5 years, you will definitely need that kind of training in terms of lifestyle medicine.
We'll keep in touch regarding the same.
Oh, sure, definitely. You can log into
so
the Indian Society Lifestyle Medicine website. Yeah.
The gentleman in the audience would like to ask a question.
So one thing about chloramphenicol. Previously, we used for enteric fever.
Yes, sir.
But on chronic use, it may leads to bone marrow depression.
On
Throughout
chronic.
the world, it is banned. We are
Yes,
not
sir.
also using.
No, available, sir. Now it is revoked.
We are using or not using?
We are using now.
What for? What are the indications for chloramphenicol nowadays?
Klebsiella
But
mostly.
we are not using here. We are not totally, we are not using.
MDR or
And
HDR?
other countries also, Western countries, they are not using. Banned.
No.
Totally banned.
No, sir, it is not banned in India.
Yes.
Yeah, it is
what
not
for
banned.
you are using?
The MDR Klebsiellas or XDR Klebsiellas, which are even resistant to colistin, tigecycline, carbapenems.
How long, madam? How long will
We give it for 5 to 7 days. The good thing about the chloramphenicol, 100% bioavailability.
Yes, that's good.
100% bioavailability in all the organs. So whenever you are getting any susceptibility, antibiotic susceptibility, culture sensitivity report, it is not that you can't, you can write the medicine whichever is sensitive there, right? Like nitrofurantoin, urinary tract infection. They would have put nitrofurantoin sensitive. You say, okay, nitrofurantoin is there, write this medicine for the patient, okay? But you must be aware, nitrofurantoin only works in the lower urinary tract, not on the upper urinary tract. So with your diabetic patient, you are dealing with pyelonephritis or renal abscess, nitrofurantoin won't work. It will work if only it is a cystitis. So all these things, nitty-gritties are involved. The chloramphenicol, if all the drugs are resistant, if you in your culture sensitivity, you will see that chloramphenicol is not even mentioned. I go around 50-60 hospitals in the city where they don't even have a good microbiology culture sensitivity reports.
But
So
mostly in the corporate hospital setup, we
it
are
is
not
available.
using, we are using higher
Those
antibiotics.
who know, like CMC Vellore or Apollo Hospital, Sundaram Medical Foundation, those who know, they will mention if everything is resistant, In the last line, they will mention chloramphenicol sensitive. Given the background of the patient, the disease condition, yes, you can still use. Many of the times I write chloramphenicol for even bone infections, where especially the orthopedic bone infections, where they have done knee replacement and the knee gets infected and the orthopedician says nothing we can do, 78 years knee replacement done. Back to the family physician, you have to deal with it. So he says, இப்போ மறுபடியும் எடுத்து சிமெண்ட் தான் போடுவோம், சிமெண்ட் ஸ்பேசர் தான் போடுவோம், அப்புறம் கால் அப்படியே நீட்டிக்கிட்டே இருக்கணும் பேஷண்ட்டை, இன்ஃபெக்ஷன் ஆகிடுச்சு, இல்லாட்டி மறுபடியும் 6 மாதம் கொடுத்துட்டு இன்ஃபெக்ஷன்லாம் கிளியர் பண்ணிட்டு வாங்க, அதுக்கப்புறம் இன்னொரு முறை நாங்கள் ரீப்ளேஸ்மெண்ட் பண்ணுவோம்னு சொல்லுவாங்க. ஸோ யூ வில் பி அகெயின் சீயிங் திஸ் பேஷண்ட்ஸ். Gone are the increase in this knee replacements and other replacements happening, arthroscopic procedures happening. Many times it gets infected and they are back to us, the family physician, where they will be in the prolonged antibiotics. Sometimes we deal with MDR bugs from the hospital acquired infections, where you have to see, even if they start chloramphenicol, we will be the one, we will see whether patient is going in for bone marrow depression or not. You will be doing the CBC, you will be doing the liver function and kidney function, you will be the one alerting. So, this is not responding, should we have to change the antibiotic? So, we are going to be the forerunners. Don't think only treating malaria, dengue. Gear up for seeing this hospital acquired infections which are going to come back to us from the hospitals, where you will be seeing the stent infections, urinary stents put, the patient coming back, the replacement infections, any other implant infections, they are going to coming back to you, because the number of the surgeries going up, number of the infections in the hospital is also going up, the diabetes is also going up, they will be coming back to the family physician. You are the ones going to see these infections coming back from the hospitals, and you have to tell whether it is the hospital acquired, it is the community acquired, what is the antibiotic you have to give to the patient, the follow-up, whether they are going to get the side effects, like ma'am was mentioning, the side effects. You are the one going to see, you are the one going to write up the antibiotics, none else. Just like how you took up the diabetic in your hand, it is going to be antibiotics in your hand. But use the weapon properly. Whether you are going to use the, okay, I will start with Tamil now. Okay. நீங்கள் தடி யூஸ் பண்ண போகிறீங்களா, கன் யூஸ் பண்ண போகிறீங்களா, இல்லை மிஷின் கன்னா, மிசைலா, இல்லாட்டி பயோ வெப்பனா, இதுதான். ஸோ வந்துட்டு எதை தடியால் அடிக்கணுமோ அந்த ஆன்டிபயோட்டிக் யூஸ் பண்ணுங்கள், எது வந்துட்டு மிஷின் கன்னால் கொல்லணுமோ அந்த ஆன்டிபயோட்டிக் அந்த சமயத்துக்கு யூஸ் பண்ணுங்கள். பெட்டி தீஃப்கெல்லாம் வந்துட்டு மிஷின் கன்னும் மிசைல் பவரும் யூஸ் பண்ணிடாதீங்க. Paraxin is golden drug. I will keep it aside now, because இதை தவிர வேறு எதுவுமே என் கையில் இல்லை. இந்த மகாபாரதத்தில் ராமாயணத்தில் வில்லு அம்பெல்லாம் போகிற மாதிரி இருக்கும்ல, அந்த மாதிரி எல்லாமே போட்டு தீர்த்துருக்கேன். I have seen a renowned pediatric cardiothoracic surgeon's father dying in front of 10 doctors in a big cardiothoracic hospital. ஒரு pediatric surgeonோட அப்பா dying in front of us because of this bad Klebsiella in front of us. We are helpless. None of the antibiotic is working. We give colistin, tigecycline, even Paraxin. Blood cultures திரும்ப பண்ணி பார்த்துக்கிட்டே இருக்கோம். Culture is still positive. The Klebsiella won't leave him till it takes his life. It took. A pediatric surgeons. It was very heartening. That day I felt like, what am I dealing with? Seeing in the hospital and doing, I am helpless without any antibiotics in there. Then I said, I have to go back to my roots as a family physician. I have to start clearing up. We have to gear up for that kind of, the moment happened in the Switzerland where they started changing the antibiotic. I have to do that. Chloramphenicol, hold it gold or platinum, whatever it is. Don't use it in the practice now unless you don't have anything else to deal in your culture sensitivity. That time you take up that last Brahmastra.
Nitrofurantoin, wonderful drug. Nitrofurantoin we are using.
Only for lower urinary tract, not upper urinary tract. If you are not sure whether it is not in the abscess, because I have seen people with abscesses in the kidneys.
Running short of time, I'm extremely sorry to cut short this interesting conversation that was going on. Last word of comment from the chairperson, and then we are good enough to go back to your home.
Thank you all. Really scintillating conversation, wonderful conversation. Just maybe two things to take home from this really rich panel. The first is, as a family medicine doctor, you are the master of your own destiny. Look at each of them. And what I found remarkable was they went through these seasons in their career where they specialized, but one of the things which came up again and again was their primary, their primary foundational identity and the foundations of practice in full spectrum family practice. So that's really wonderful to see. Kailas?
One thing to add to Dr. RK, that is, I have started my family medicine journey from 2014, and I've been to so many conferences. And everywhere we will start discussing what is family medicine, what about family medicine, how you go about in family medicine. From the, it's like from the discussion has changed right now. From what is family medicine to how can you grow up to be a family medicine doctor with a special interest. That's actually a change in the era, and that shows the need for a family medicine doctor in the society, and how the young doctors or the doctors with practice are being accepted in the community. So to all the PGs, gear up for a bright future ahead. All the best. Thank you. And congrats to the Tamil Nadu team for organizing such a wonderful conference. Thank you.
Thank you, sir. I would like to request Dr. Roshini Ganguly ma'am to honor the speaker and the chairpersons. Thank you, ma'am.